Hello everyone. Today we are going to talk about intensive lipid lowering therapy following patients of acute coronary syndrome. So in acute coronary syndrome, the patients behave differently when compared to a stable patient. So always remember that all the patients of acute coronary syndrome, whether it may be STEMI, NSTEMI, or unstable angina, all patients have very high risk of recurrent cardiovascular events. That means they can always get a future another ischemic event is highly likely in those patients. So the first few weeks are very crucial period, and that's why it is called as the most vulnerable period. So elevated LDL cholesterol contributes to ongoing atherosclerotic risk. So that means if there is high LDL levels, always there is chance that another ischemic event can be occur sooner. So that's why we need to aggressively and early to reduce this LDL level to as low as possible so that such future events can be prevented. So what is the rationale for early therapy? That LDL cholesterol is linked with a high cardiovascular risk. So delayed treatment escalation leaves the patient above target during the high risk period. So early weeks of the time after the acute coronary syndrome is the most vulnerable period. And if you do not reduce LDL very early during this period, the patient may get an ischemic event. So aggressively you need to treat LDL during this period. So rapid therapy may help prevent recurrent MI and other major cardiovascular events. So targets how much LDL cholesterol should be reduced is an important thing which every medical resident or a doctor should remember. Always, whenever you start a therapy, first what you should need to do is you need to do a baseline LDL level, and after therapy, the cholesterol level should reduce by at least 50%. Usually, repeat cholesterol levels is checked usually after around 4 to 12 weeks. So if you take also mean also around 6 to 8 weeks time, the cholesterol level should be reduced by at least 50%. That means suppose the patient LDL was 100, it should come to 50, or the ESC recommendations say that it should be below 55. Or if any patient has a second vascular event, so after control also, if there is another recurrent event which is occurring in this patient, suppose patient of MI again get re-MI, then the target of cholesterol should be less than 40 milligrams per deciliter as per the ESC guidelines. The Lipid Association of India recommends LDL cholesterol level should be below 50 after ACS, and in selected cases it should be maintained below 30 milligrams as well. So baseline lipid assessment, always perform a complete lipid profile during admission itself, and baseline LDL cholesterol helps guide treatment intensity. So always start all the patients of acute coronary syndrome with high intensity statins. So common regimens, that means we use is atorvastatin and rosuvastatin. So if you're starting atorvastatin, always use high intensity, that is 40 to 80 milligrams, and rosuvastatin is 20 to 40 milligrams. So statin is found to have a high effectively reduce LDL cholesterol. They also reduce inflammation, stabilizes the plaque, and improves the endothelial function. So your guidelines is now suggesting upfront combination therapy, that is use statin along with some other drug. So most commonly which has been recommended in the latest guidelines is statin plus ezetimibe upfront. You should start in patients, and it should be 10 milligrams of ezetimibe with statin, either atorvastatin or rosuvastatin. So this is preferred instead of waiting for statin failure. So this combination therapy is found to be highly effective rather than waiting for the first 4 to 6 weeks, which is highly vulnerable period. And during this time, waiting for the statins to work, and suppose if it doesn't work, we may unnecessarily risk the patient to for another ischemic event. So upfront start combination therapy. So ezetimibe provides an additional around 20 to 24% of LDL reduction as per the studies. Also, it will reduce the LDL levels very faster. So suppose after first 4 to 6 weeks, if the cholesterol levels are not reduced, you can add the third drug as well immediately. That is the triple lipid lowering therapy. That is statin plus ezetimibe, and the next drug you can add is either bempedoic acid, or you can add PCSK9 inhibitor. Triple therapy is useful when dual therapy is unlikely to reach the LDL targets. So one study, that is LAI React, showed that about 60% of LDL cholesterol reduction occurred within 1 week itself with the therapy. So what is the role of PCSK9 inhibitors? PCSK9 inhibitors such as evolocumab and alirocumab produce profound LDL cholesterol reduction. They are especially useful when very rapid target attainment is needed. The study, that is EVOPAX study, showed LDL cholesterol less than 70 in about 90%, 95% of patients. So more than 90% achieved LDL cholesterol to less than 55 by 8 weeks when added early after the ACS. So what are the evidence from the clinical and plaque benefits? Is the first study was Pacman MI, which showed reduction in plaque volume and lipid burden. Huygens study, which also showed increase in fibrous cap thickness with early reduction of LDL. And Swedheart study also showed fewer cardiovascular events with early statin ezetimibe therapy. So monitoring always repeat lipid profile after 2 to 6 weeks. Then you should, once it is within the target range, you should do it once every 3 to 6 months. In conclusion, always